Welcome to the Mental Health Policy Briefing, Raising the Priority of California Children with Special Health Care Needs. My name is Holly Henry, and I am the Research Program Manager at the Lucille Packard Foundation for Children's Health. The Foundation is honored to have you join the briefing today with experts from the National Health Law Program. A few housekeeping items before we begin. Our briefing will be 30 minutes, with the speakers staying on after to answer audience questions. We want to provide as much information as possible, so please stay on if you have the time. You can submit questions through the questions box at the bottom right-hand section of your screen. A recording of this briefing and the slides will be posted on the Foundation website and shared with all registrants via email. Now on to today's briefing. As you may be aware, our foundation is focused on improving the system of care for children with special health care needs and their families. From access to care to improving coordination and ensuring that disputes about coverage are resolved in a timely fashion, the mental health system in California is in need of improvement. Alarming new data from kidsdata.org, a program of the foundation, shows that in 2017, the highest percentage of hospitalizations among youth in California was for mental health reasons. In fact, mental diseases and disorders accounted for 14% of hospitalizations, which is almost twice the rate due to asthma. This is a new trend we're seeing and highlights the importance of addressing this public health issue for all children. Today, our speakers will share an overview of the mental health services and supports to which children with special health care needs in California may be entitled, highlight the current policy landscape for supporting the mental health of our children, and provide opportunities and action steps for engaging in advocacy efforts. Now I'd like to introduce our esteemed speakers, Kim Lewis and Abby Corsall from the National Health Law Program. They are experts in improving access to quality health care for low-income and underserved individuals in California, with an emphasis and expertise on mental health services under Medicaid's mandate for children, the early and periodic screening, diagnostic, and treatment obligation. Now I'd like to turn it over to Kim and Abby.
Good afternoon, everyone. This is Kim Lewis. I'm the Managing Attorney of the California Office of the National Health Law Program. It's great to be with you today. I wanted to just start by giving you a little information about our organization. So we are a national public interest law office that works on behalf of low-income healthcare individuals and working primarily in the area of Medicaid, the Affordable Care Act, and the marketplaces. So our work really focuses on populations' access to health care, making sure that that health care is affordable and accessible to all low-income individuals. We have 3 offices. The office that we're talking to you today from is our California office in Los Angeles. We have an office in Washington, D.C., as well as in North Carolina. We do a lot of different types of advocacy here at our office. So not only are we doing administrative or policy advocacy with federal and state agencies, we also do litigation in the area of Medicaid mostly, but other programs as well. And we also do education and training and provide support and technical assistance to advocates, predominantly healthcare advocates and legal services advocates across the country, including in California, as well as with other stakeholders who may need technical assistance or help in navigating certain parts of the healthcare law. So that's the kind of work that we're doing here, and we do a lot of that work in California. So very familiar with the structures here and working with the state on all kinds of Medi-Cal and healthcare related issues. So going on to the next slide. This is an opportunity, I think, at this time in our state to really accomplish things and to move healthcare policy forward in a way that maybe we haven't in the last 8 years. We have new leadership, and we have obviously a new governor who is just starting out in his tenure, Governor Newsom, and He has prioritized children as one of his areas of interest and concern, and in particular healthcare access for children. And he also has prioritized mental health services, and in fact is planning to name a mental health policy advisor or mental health czar to his leadership team, although that has not yet happened. But in addition, he has appointed two other individuals who are here on the slide. One is the first, one is the first Surgeon General in California, and that is Dr. Burke Harris, who is a whose top policy priority and kind of focus area has been to raise awareness around adverse childhood experiences, such as emotional abuse or witnessing domestic violence, and has really focused on how increasing the risk of major health problems like asthma and diabetes and heart disease can result from exposure to many of those ACEs or adverse childhood experiences. So she is going to be a leader, I think, for the governor in a lot of these areas, but in particular focusing on the impact of these childhood adverse experiences on health and in California policy. So that's really an opportunity to work with a new leader, which I think is really not unique to our time here. In addition, Dr. Mark Galley was just recently appointed as the Health and Human Services Secretary, and he has a great deal of experience. He's a practitioner. He's a pediatrician that is a current practicing pediatrician and former director of health and social impact for Los Angeles County. So not only is he a physician, obviously focused on children, but he also is a public health expert. And so he has a great deal of knowledge and understanding about community health outcomes and how that intersects with law and policy issues. He's worked on whole person care as part of the Medi-Cal waiver to ensure adults with mental illness get access to housing and other supports, and also is going to be very involved in the governor's healthcare agenda in terms of ensuring access to affordable healthcare and coverage for undocumented individuals, and also working on the path towards full healthcare coverage, including possibly single-payer healthcare. So this leadership team is new and I think dynamic and very interested in children in particular, and so this is an opportunity for us.
Thanks. Next slide. So we then wanted to give you just a little bit of background about how mental health services are delivered in Medi-Cal with a particular focus on children with special health care needs. Next slide. So as many of you may know, we have sort of a bifurcated delivery system for mental health services in Medi-Cal today. We have our Medi-Cal managed care plans, which provide a wide variety of physical health services to children and adults, but also are responsible since 2014 for providing certain non-specialty mental health services. And you can see the list on your screen, but this includes things like individual and group therapy, psychological testing, drug monitoring, and lab services and psychiatric consultation. And then on the substance use disorder side, it includes screening and brief intervention and referrals to treatment for alcohol abuse. Then on the other side, we have county mental health plans, which are specifically responsible for specialty mental health services and specialty mental health services only. And they're really aimed, or their target population is children and adults who have a more serious mental health condition. Adults with a more severe mental health condition and children with a range of mental health conditions. And again, you'll see on the screen the list of outpatient and inpatient services that are covered by the mental health plans. They include things like assessments, plans, rehabilitative services, day treatment services, crisis intervention and stabilization, targeted case management, and then a range of EPSDT specialty mental health services that we'll talk about more in a minute. And then on the inpatient side, it includes things like, acute inpatient hospital services, psychiatric health facility services, and certain types of hospital professional services. Next slide. So because we have this bifurcated system, of course, there has to be some way of determining whether people need specialty mental health services versus the non-specialty mental health services that are offered through the managed care plans. So as part of the regulations in California, the state has laid out the criteria that give people access to specialty mental health services. So you have to have a certain diagnosis, and there's a list of about 18 different diagnoses that are eligible for specialty mental health services. The condition can't be responsive to physical health care treatment. You know, if a condition can respond to physical health treatment, then it stays on the managed care plan's responsibilities. And then you have to meet the medical necessity criteria. And for adults, generally you have to show that, as I mentioned, that the condition is severe and would be responsive to treatment. For children, the criteria is more relaxed, as we'll discuss in a few moments, and just have to show that the treatment that's proposed would correct or ameliorate the underlying condition. Next slide. So to determine where you go to get your mental health services in Medi-Cal, there are these sort of different stair steps that can get you access to mental health treatment. Many people will start with their primary care provider, who can provide a basic assessment and some screening, and refer someone on to get more specialized mental health services. Then the managed care plan, the health plan, has a network of mental health providers who again can provide screening and a more comprehensive assessment to determine what someone needs. And similarly, the mental health plan on the specialty mental health side has providers who can provide an assessment. And you'll see on the screen the assessments, whether it's coming on the health plan side or the mental health plan side, they should be using the same tool and reaching the same conclusion. So the idea is that, you know, no matter who is assessing you to determine what you need, the results should be the same, whether that's happening from the health plan side or the mental health plan side.
Next slide. All right, so now we're going to talk a little bit more about special rules that apply to children under age 21. And obviously that is the population that we're focused on today. When we talk about children with special health care needs, we're generally talking about youth, children and youth. However, it's important to know when we talk about children from the Medicaid standpoint, from a legal perspective, we are talking about some young adults, because the term EPSDT comes into play, which, as you can see on this slide, is called early and periodic screening, diagnostic, and treatment. That's a term that is from the Medicaid law, the federal law, and it applies to children on Medi-Cal or Medicaid who are under age 21, so all the way up through your 21st birthday. So we are talking about adults 18 through age 20 as well, not just children under 18 and youth. The next slide. So let's talk a little bit more about what EPSDT is. If you are familiar with that term, you do understand that this is a Medicaid term that, that often gets discussed in policy arenas and around the state, because it is an entitlement. And so when we say Medi-Cal EPSDT, we're talking about the rules that apply through the Medicaid program or Medi-Cal to children. And this entitlement means that they are able to get services, or we call mandatory services, that otherwise you would not be able to receive as an adult. So over age 21 and older. So that's really critical, because some state plan services, every state that provides Medicaid services has a state plan, which is their essentially contract with the federal government about what they cover. Some services are mandatory and some are optional. But for children, all services, regardless of whether they are covered for adults or not, are mandatorily have to be available to children. So those are what we call mandatory services in Medi-Cal. So that is the Medicaid entitlement itself, that those services must be made available even if adults can't get them. And so the state, and in California, we have 80% of our population in managed care. So managed care health plans, as we've talked about, there are two types, the health plan and the mental health plans, but the Medi-Cal managed care health plans must screen all children. Their obligation under EPSDT is to screen children for a whole variety of needs, for health and behavioral health needs. And because of that screening obligation, there's a periodicity schedule at which, along a developmental timeline, they're required to see children and ensure that they meet the developmental milestones they're supposed to, and also between those time periods as needed when symptoms arise or a child demonstrates a need for a particular evaluation or service. So that broad entitlement means that managed care plans, or if a child is not in a managed care plan, that they would be able to see a pediatrician in fee-for-service Medi-Cal to identify those needs, just screen for those particular needs, including behavioral health or mental health needs. And the medical necessity criteria, which is the T part of EPSDT, the treatment, is a broad obligation as well. So unlike adults, and Abby read that earlier slide talking about the adult medical necessity standard, the medical necessity standard for children is a broad entitlement definition. It means all treatment must be covered that's necessary to correct or ameliorate a condition or an illness, even if the service isn't in the state's plan. So that means, as I said, all mandatory Medicaid services, which is the entire list of services the state could provide, are services that children would have to have access to if those services are necessary to correct or ameliorate a standard, an illness or condition. And so it's important because sometimes limitations or limits on access get put into place for adults, like you can see, let's say 2 counseling sessions for an adult per month. A plan might have that limitation. For children, you can't place that same limitation on them in terms of limiting access. It's whatever is medically necessary. Let's go on to the next slide. These are a couple services that I think is important to know about. These are specialty mental health services, but these services are a bit unique in California because they came about both in their name and their type through lawsuits in California over the history of the state. So there's 4 services here. The first one, Therapeutic Behavioral Services, or what we call TBS, came about through a lawsuit called the Emily Q lawsuit against the state. And that essentially provides for again, for children under age 21, those children with serious emotional disturbance who have a need for a very short-term treatment intervention. It's an intervention within the home or the community, or it can be provided in a group home where a child is residing, essentially anywhere. And there's a sort of therapeutic mentor or a provider that assists the child in certain behavior redirection or skill building in a very short-term way that works under the supervision of a clinician. And so that TBS service has been available since the late 90s. Now, the other 3 services, intensive care coordination, intensive home-based services, and therapeutic foster care, are more recent additions, but those came about through the KDA lawsuit, and that was provided on behalf, that initial case was on behalf of children in foster care, but these services are now available to all children in Medi-Cal if they need them. So children with more intensive mental health needs in particular would get access to intensive care coordination, which is a robust care management team-based approach to care planning. It's an actual service where multiple individuals who are a part of a team that develop a care plan could bill to this service at the same time. So it's not a single person. And that service can be essentially is necessary to ensure that kids who are in multiple systems like juvenile justice or child welfare or have special education are able to access services that they need through a much more robust care coordination model. And so that's what intensive care coordination is. Intensive home-based services are similar more to the TBS model. They are where you provide services in the home, in the community, in the school, anywhere the child resides, and there's no limits on the amount of time that can be provided. Where it's under the rehabilitative model in California, you would allow a child to get develop skills and learn to manage behaviors through a provider that would help to have the child learn those behaviors, or to provide those to the caretaker, like a parent or other caretaker, in order for them to be able to intervene with the child and through this sort of behavioral plan that would allow them to change behaviors and manage behaviors that would allow them to function better in school or out in the world. And then therapeutic foster care is a more recent addition, and this is more of where you have a professional parent model outside of the home where the child can't reside in the home, but they are placed, let's say, in a foster home or in another setting where they're not with their actual biological family or primary caregiver. And that therapeutic foster care parent or professional parent would essentially be also billing to Medi-Cal, and they would be implementing a treatment plan on behalf of that child. So they're part of the team of providers that work with the child, and obviously they live in the home with that parent. So let's go on to some of our other issues.
Thank you, Kim. So we wanted to spend a little bit of time talking about sort of what we're doing now to address some of the policy issues we see. And I think at the end we'll give you a list of some of the resources and reports that we and others have put out over the last few years, highlighting some of the gaps in our current delivery systems and the places where children with special health care needs in particular, but Medi-Cal beneficiaries more broadly, are not able to access mental health services that they need. Next slide. So one of the key ways we're aiming to address some of those gaps is through a bill that we're co-sponsoring this year along with the Western Center on Law and Poverty. That's AB 1175, authored by Assemblymember Wood. And the goal of this bill is really to improve the relationship between the county mental health plans and the Medi-Cal health plans. Because we have this bifurcated system that we talked about a few moments ago, as you can imagine, there are a lot of opportunities for people to fall between the cracks or to get referred back and forth from one plan to the other and go without the services they need. So this bill is taking sort of 4 different approaches to try to close some of those gaps. First, by improving the requirements for coordination of care, especially when people move between plans, and implementing for the first time a uniform requirement that plans would have to track referrals when they send someone. If they say, you know, a health plan says, we think your mental health condition is such that you require specialty mental health services, that they would have to keep track of that referral and do some follow-up to make sure that the person followed through with the mental health plan to access those services. In addition, more data collection more broadly, again, sort of to what I just mentioned, trying to have some tracking about what happens when people are going back and forth between plans or when a request for service is denied, so that we have a better understanding of what people are seeking in terms of mental health services and what they're able to access. The third area is continuity of care. Right now there are some informal requirements that require plans to provide continuity of care if somebody is receiving, for example, therapy services from their Medi-Cal health plan and their condition is such that they require therapy services in a specialty mental health environment, trying to ensure that that person can keep seeing their existing therapist with whom they've already established a relationship if that's appropriate. And then the final area is around resolving disputes and really strengthening those requirements, particularly in the instance where you have someone trying to seek mental health services from either plan and both plans are saying it's not my responsibility. Having a streamlined and formal way for people to for the plans to resolve that dispute to make sure that the person actually gets some mental health services that are medically necessary. Next slide. A few other bills that are on our list for this year that we wanted to just flag for you all to keep an eye on as well. AB 763, this is really about the providers in the mental health plans and making sure, pediatric providers in particular, making sure that it's easier for them to participate in Medi-Cal and also streamlining the assessment process that determines whether people get services and what level of services. AB 512, again, focused on the mental health plans and would require more reporting on cultural competency and some monitoring of disparities in terms of the services people are getting through the mental health plans. AB 1676 would expand the use of telehealth to provide access to mental health services during pregnancy and the postpartum period, recognizing the high prevalence of perinatal and postpartum mental health conditions in our state. SB 12, which requires the state to uniformly establish access to more peer, parent, and family support specialists. These are services that are offered on sort of a pilot basis in some places in the state, but aren't available in all areas of the state. So this would try to expand those services statewide. And then finally, SB 12, which would establish an integrated youth mental health program. And this is through the Mental Health Services Act, which is, another source of funding for many mental health services in our state, and would establish these integrated service centers for youth aged 12 to 25 and their families. So just a few of the bills that we're watching that could have an impact on how mental health services are delivered in our state. Next slide. And then in terms of administrative advocacy, these are some of the places that we have been engaged to be talking to the state about mental health services, and places that others could engage as well. And all of these, the four groups on the right-hand side of your screen, meet on a quarterly basis. So you have the Medi-Cal Waiver Stakeholder Advisory Group, which is really sort of the place that looks at Medi-Cal program as a whole, including, both on the health plan side and the mental health plan side. So it's a way to talk about the mental health issues and gaps that sort of cross all sides of the house. The second one is the Medi-Cal Managed Care Advisory Group, which is the advisory body that's tasked with overseeing the Medi-Cal health plans in particular. And so, looking at the non-specialty mental health services that those plans deliver, that's the task of that advisory group. There's also the Medi-Cal Children's Health Advisory Panel, which has a specific focus, as the name suggests, on children's issues and children's access to services. And then just a few weeks ago, the state announced that it will be launching a behavioral health stakeholder advisory committee. The first meeting will take place in July. So we don't know a whole lot about what that will look like or what its scope will be yet, but we're very excited that the state has recognized the need to focus on behavioral health specifically and is establishing an advisory committee to do that. And then just to flag for you all, one of our policy priorities this year is really implementation of a bill that we worked on last year, SB 1287, which codified the medical necessity standard for early and periodic screening, diagnosis, and treatment that Kim reviewed a little while ago. So we're working with the state to make sure that is really written into all of the guidance that the state is putting out to families, to providers, to health plans, to mental health plans, to make sure everyone understands that children in Medi-Cal should be getting services whenever they're necessary to correct or ameliorate a physical or mental health condition.
Next slide. So this is we're going to talk a little bit, very briefly, about ways to engage in policy advocacy. So let's go on to the next slide. So there are a variety of sort of ways that you can get involved as a consumer or as a family member or other. There are boards and commissions that either some of the local health plans or mental health plans have. I know that counties have mental health boards where you can, there are public meetings, you can go and talk about mental health issues that are arising in the county in particular. There's obviously the Board of Supervisors that counties have, which are their governance bodies, and they have public hearings and do take testimony as well on particular issues that are on their agenda. And then provider associations or provider organizations, there's the medical boards and professional associations that exist in the state or locally, where you certainly can go to, to have input or to talk about issues that are impacting your local community. And then stakeholder meetings. Some of the ones that were mentioned earlier, obviously, are the state Medi-Cal meetings, which we just discussed, which are open. There's the MHSA Mental Health Services Act community planning process and the Oversight and Accountability Commission. That commission oversees the delivery of funding on the Mental Health Services Act, which is Prop 63. That is a whole source of additional funding for communities and counties to be able to determine how mental health dollars can be spent within the plan that they develop locally. And they also take, so that statewide body oversees that, but also there's local committee meetings as well, or local process for input on a local plan. And then plan and provider, again, organization advisory groups. And then sharing your story. with the press, letters to the editor, op-eds are another way that you can get information out there talking about problematic cases or about issues that are impacting your, your family, your community, and there's always interest in particular mental health in the newspaper. Let's go to the next slide.
Great. So also just want to quickly flag some resources and some groups to follow if you're interested in these issues. Next slide. So some advocacy groups to be aware of. One is the Health Consumer Alliance, which is a collaborative of 18 different legal services organizations around the state that can provide direct representation and advice on individual cases where you have children with special health care needs or others who are having difficulty accessing mental health services. Disability Rights California, which is California's protection and advocacy program that focuses on the rights of individuals with disabilities in the state, and again can provide individual case assistance and advice for people with disabilities who are having difficulty accessing mental health services they need. The California Children's Trust, which is a relatively new organization that's focused on re-envisioning the behavioral health delivery system for children and doing advocacy in that area. And then Family Voices, which is a collaborative of parent-run centers working to ensure quality health care for children with special health care needs. Next slide. And then finally, just wanted to flag some additional resources and information. I mentioned some of the reports that our organization has put out. You can see the list of 4 of them we've put out since 2017 on your slide. And then from the state, there are 2 model beneficiary handbooks, one for specialty mental health services and one for managed care plan services broadly, including non-specialty mental health services. So those are 2 places to look for additional information about the services in Medi-Cal. Last slide. This is to us, Kim and Abby, and our contact information. Of course, you can ask us questions now, but if you want to contact us later, this is how to reach us. We'll turn it back to you, Holly.
Well, thank you very much, Kim and Abby, for the informative overview. I want to remind listeners that the slides and a recording of this briefing will be available on our website, and all attendees and registrants will also be automatically emailed when the materials are available. Audience members that have submitted questions or are interested in hearing more from the speakers are welcome to stay on the line now. So we have several questions coming in, and I would appreciate if listeners continue to ask questions that you want to learn more about from Kim and Abby. I'll start with the first here, which is, what, if any, preventive mental health services is the state of California required to offer under EPSDT?
Hi, this is Kim. I will start with that question. So, it's important to understand, as I talked about EPSDT earlier, early and periodic screening, diagnostic and treatment program services. So screening, I mentioned, is a sort of fundamental part of providing prevention. So whether it's immunizations that are provided or covered under Medi-Cal, or it is screening a child as for the developmental milestones, full annual checkups and visits to determine whether there is a particular need, whether it's a vision or hearing or health or behavioral health need. Those are all services that are specifically covered under Medi-Cal. So it's a very broad sort of identification process. And, there's quite a few other types of services that could be provided. I mean, sometimes educational services, outreach, things like that are covered as well. It's just in the context of a particular type of need or service. But I think from a standpoint of, prevention, other than immunizations, which are clearly a preventive service, it's really that identification of a need and then obviously treating the need based on the very broad obligation that the state has to ensure that they're followed up with an assessment and a diagnosis and then treatment for whatever that particular need is. So I think that's probably the best way to describe it, as a prevention model.
Thank you. Our next question is, Are there any services available for substance use disorders beyond short-term treatment?
This is Abby. Yes, there's a variety of substance use disorder treatment covered through Drug Medi-Cal, and in several counties now in the state through our waiver program, there's the Drug Medi-Cal organized delivery system model that's being implemented that offers an even broader array of services. So one of the resources we listed on the previous slide is a paper that our office put out in February that gives a more comprehensive overview of substance use disorder services in Medi-Cal. So I would refer you to that paper, but there are quite a variety of services covered in Medi-Cal.
Thank you. Next, a little bit of a more broad question. Can you both speak a little bit to the shortage of providers for mental health services for children in our state, as well as the impacts that you see of low reimbursement rates for their services?
Sure. This is Abby again. I can talk a little bit about that. I mean, certainly this is an issue that's well documented, and not just in California, but nationally, that there is not enough. There are not enough mental health providers to meet the demand, and particularly when you're looking at mental health providers with a pediatric specialty. So that is a broader problem, and I know it's something that our state is looking very closely at, and that is getting a lot of attention nationally. Here in California, there has been particular concern because our Medi-Cal reimbursement rates are comparatively low. We usually rank somewhere around 45th among states, even though our state has, as I'm sure you all know very well, a very high cost of living. So that is a cause for concern. Prop 56, which the voters passed in our state a couple of years ago, has provided some additional funding for certain types of providers, and that's something that will continue to be reevaluated by the state over time. But I think this is something that everybody is thinking really hard about, and part of it is one of the bills I mentioned earlier, looking at expanding the range of people who can deliver mental health services. Not everybody needs services from a psychiatrist, for example, and there are other types of people who can provide services that can be very effective, but also obviously just expanding the number of providers who are available in Medi-Cal more broadly.
And this is Kim. I would add a couple of additional points. One is, clearly, as we know, we talked about, this is an entitlement, so a lack of unfortunate, low rates does not mean the state doesn't have an obligation to provide services that are medically necessary in a reasonably prompt manner. And so that is something that can be enforced, clearly, with the state. In addition, there are new managed care obligations to provide geographic and timely access to care. Those new standards are in state law. They came about through federal Medicaid managed care changes, and so all states have to have these timely access standards and network adequacy. And so health plans in California and the mental health plans in California are obligated to ensure that there is timely access to care, both in psychiatric services as well as other outpatient mental health services. And there's geographic time standards that apply depending on the size of the county in terms of time and distance. And then there are also specific 15-day requirement to get access to psychiatric services and 10 days from request to get access to other outpatient mental health services. And so those are enforceable standards that are new that should be looked at as a part of this. And then finally, I would just say that there is a need, always for more psychiatrists and clinical specialists or clinical professionals, but in the mental health arena, a large part of psychiatric outpatient services or mental health services and supports are provided through paraprofessional models. So the peer support services we talked about earlier, family, parent partnerships, providers, peer mentors, those are services that can be provided by fairly, somebody who doesn't have to have a clinical degree, and somebody who could be a college graduate or have an experience level of having the knowledge that even a clinician may not have. And so they work under the supervision of clinical staff, and many of the counties, really pretty much all of them, allow for this type of provider, and they're very frequently provided in the community to children with severe emotional disturbance or or other mental health needs. So that's, I think, a way to address also an expanding role that can address a clinical shortage.
Thank you. Could you speak a little bit to what types of crisis services are required for youth in California? And this listener is specifically interested in hospitalizations or serious mental illness type services.
Sure. This is Kim. So, I mean, there are different types of crisis services. And again, let's talk about EPSDT. So this is a broad entitlement for children as opposed to just adults where there may be fewer such services available. But there's crisis intervention services, and those are generally services provided in the community. So somebody comes out who's a provider to a situation, it could be anywhere that the child is located. It could be a school site, it could be at home, it could be in the community, anywhere. And that crisis would be ameliorated or addressed through, the application generally of a crisis plan, where you would say when particular behavior occurs or an incident that you would have a plan on how you're going to mitigate or address that crisis. So those services are, again, very mobile. So that's mobile crisis. Sometimes it's called mobile crisis intervention. So those are services that apply anywhere. Alternatively, more crisis stabilization services are where you bring the child, into a center or hospital or other setting where you would have more of a short-term crisis stabilization unit that the child would reside at until the crisis was abated. And then there are other crisis residential programs that are fairly new where you could be maintained or be treated for a short-term stay, which is longer than, say, a 23-hour stabilization unit, or where you wouldn't be admitted to a hospital. Obviously, you can also be admitted to a hospital or for a crisis and psychiatric intervention that occurs in that way, and that generally, then it's not considered a crisis service. At some point, it's an inpatient hospital service. So after you are admitted, that's a hospitalization. But the crisis can be up to 23 hours and 59 minutes, and some kids are maybe even maintained in an ER during that time, or during the crisis itself.
Thanks a lot. Sort of a follow-up question to the first question that was posed. Is education on positive parenting and infant mental health consultation a covered benefit?
I think it depends, but yes, I would say what we sometimes talk about as collateral services, or that's a sort of a term of art that's used as a billing term for providers, but collateral is essentially where you're providing services to the child by intervening with the parent or the caretaker. So that means you're helping the other person who's not the child, who's the Medi-Cal beneficiary, but you're helping the caretaker of that child or the parent of that child to be able to be educated and trained and to learn certain skills on how to intervene with that child. And so any of those kinds of educational or skill building activities are a reimbursable activity in Medicaid, and those can be billed to Medi-Cal. Obviously, you have to be they're provided by a Medi-Cal provider, so it's not that anyone can just bill Medi-Cal. It have to be a provider. It doesn't have to necessarily be, as I said, a clinician. It can be a professional that's working under their supervision who's doing the education or outreach, like a health worker of sort, in a healthcare context, or a home nurse for that matter. So those certainly are services that can be provided, and I think it really depends on the mental health. We're talking specialty mental health here. Generally, it depends on the mental health plan and some of the sort of breadth of services that they are making available through their providers in their network.
Great, thank you. That's helpful. Could you talk a little bit about the triggering mechanism, for intensive care coordination versus an intensive home-based service?
Yeah, so ICC, or intensive care coordination, is really, it fits under the umbrella of what we call targeted case management, which is a Medicaid service that's, in the federal law. But what happened in California and the way this was expanded or developed is it started with children in foster care, but the policy currently with the state through the Department of Health Care Services and Department of Social Services is that any child who has a mental health need who is also in foster care or in the foster care system is entitled to intensive care coordination. And the purpose of that service is essentially to ensure that the child gets that care coordination between the multiple systems they're involved in. It has to be, it is a specialty mental health service, so it is provided by specialty mental health providers. So every mental health plan may have a slightly different structure about who is the mental health provider that can provide those intensive care coordination services, but in a lot of counties they are, there may be an organizational provider who provides a multitude of different services like ICC and IHBS and TBS, for example, where they're providing all of those. So they know kind of what to bill and when to bill it, but there's no obligation that it be triggered or started by anyone in particular. A family or a child can ask for this service. The child welfare worker, the social worker could ask for the service, or it could be, it could be recommended by someone. So it's generally a very broad service. It should be provided much more frequently, I think, than it has been statewide. But in terms of getting access to it, it is not. There's no particular way that you have to ask for it, but it is a specialty mental health service, so it is through the mental health plan.
Thank you. A couple additional questions, piggybacking on the question before we just asked. Are there any benefits for mental health screening for caregivers?
Well, I think that's a different, there's a different question, but I think the answer would be if that caregiver is also Medi-Cal eligible, then there are obviously getting their own screening and identification needs for services would be based on their own eligibility for services. So the health plans obviously would, if they're health plan members, would have an obligation to ensure that those caretakers have access to services that they may need, whether it's, on the whole list of services that we went over earlier that the health plan's obligated to provide in terms of maybe psychological counseling or medication, identification, consultation, or things like that. But certainly there's a mental health benefit within the health plan as well as specialty mental health services for adults. But in terms of like intervening with that caretaker, and getting them their own treatment directly, that would be based on their eligibility as opposed to the child where they're, as I mentioned earlier, their collateral services are for the benefit of the child specifically, that those service skill building and other services are provided, but it is for the eligibility of the child who is eligible.
Thank you for clarifying that. Our next question is, what screening or services does California require for incarcerated transition-aged youth?
Well, I think, that's a good question. I mean, when you say what kinds of services are required for transition-age youth, again, we've talked about specialty mental health. There's a whole list of other specialty mental health services that were on the earlier slides that could be available, whether you're transitioning from foster care, from juvenile justice, or from any other system. There's not a specific list that says, okay, you must get this service or that service. It is really based on the individual need of the youth. So if a youth is Medi-Cal eligible and they're leaving a juvenile justice facility and they have a mental health diagnosis or a mental health need, they should be getting those services from the mental health plan or from the health plan as whatever services are medically necessary. So there isn't, as I said, a specific list of services that they would automatically get because it really is individualized. And if they're over 21, then they obviously only can get access to the mental health services that are available through the health plan or the specialty mental health plan that are available for adults, which is not going to be the same breadth of mandated services that children can get.
Thank you, Kim, for clarifying that. And then a final question, do you have a sense of how telehealth is being used for screening and diagnosis for mental health conditions, and whether providers are being reimbursed for using that mechanism?
This is Abby. I can start and Kim jump in. I mean, I think there's a variety. DHCS just released new guidance on telehealth for the health plans about 6 months or so ago, maybe even more recently than that. So it's been relatively, there's been some new changes that have expanded the way that health plans can use telehealth, and I think that behavioral health services is an area where many of the health plans have expressed an interest in using more telehealth services, especially given the provider shortages that we discussed earlier. So I do think that some health plans are using it, particularly for screening and assessment, but I don't know that that's uniform across the state. Mental health plans are also required to operate hotlines that provide some initial screening over the phone, but I don't think that, as a general rule, those hotlines provide like a full assessment. It may be that some of the mental health plans are also using telehealth to deliver some of those services, and Kim might be able to speak a little bit more to that.
Yeah, telehealth is clearly a vehicle for delivering specialty mental health services, and it really depends on whether that's an appropriate service to be delivered through telehealth. I mean, you have to determine whether you can sufficiently provide intervention through telehealth. And so certainly some of those services that are only available in the community and in the home, or skill building or skill development, are not going to be provided through telehealth. But maybe some psychiatric services in terms of identification of symptoms or medication may be ones that could be provided through telehealth. And I think, so there's not a one-size-fits-all approach. I think the different mental health plans are providing some of them through telehealth as needed, and in particular areas where there's a huge geographic distance between getting access to providers. And so they may be using telehealth in some of those cases to meet their network adequacy standards because of the distance of getting to a particular provider would be so great, or the shortage of particular specialists. So it isn't something there has been a lot of guidance from the state on in terms of the specialty mental health plan.
Well, again, thank you so much, Kim and Abby, for your insightful and thoughtful responses to this wide variety of questions. We really appreciate you taking the time to share with our audience today and to learn more about the mental health issues and policies that influence children with special health care needs and their families. At this time, we'd like to just provide again both Kim and Abby's contact information in case additional questions come up, that they may be able to help guide you towards the appropriate resources. And this will conclude our mental health policy briefing for today. Again, thank you for joining us.